morning, everyone, and welcome to the fifth SIRENE Capacity Building webinar, Transforming the Care of Older People Insight from the ValueCare project. As you know, probably the SIRENE project foresees a series of webinars aiming at transferring key knowledge in the field of safer, smart, healthy, age-friendly environments through the contribution of professionals and experts with different backgrounds, adopting a multidisciplinary approach aimed at integrating skills and expertise. So for today's webinar, we have the honor of having our keynote speaker, Professor Vanja Vasiljev. Professor Vasiljev is a distinguished academic at the Faculty of Medicine of the University of Rijeka, Croatia. She has a PhD in Biomedicine and a postgraduate degree in public health from the University of Zagreb. Her research specializations include public health, microbiology, and aging population. Vanja Vasiljev has a rich history of leading and participating in European research projects. Moreover, she is deeply involved in teaching public health and medicine and holds several key administrative positions, such as the head of the postgraduate specialist study program, health promotion and addiction prevention. Her extensive research portfolio includes projects on the epidemiology of hypertension, social engagement in combating chronic diseases, and integrated health and social care pathways. Today, Professor Vasiljev will guide us through the ValueCare project, an EU-funded initiative focused on delivering personalized and integrated care services to enhance the quality of life of older adults. By employing value-based methods, ValueCare strives to support healthy aging and promote independent living. Central to the approach that is adopted in ValueCare project is the involvement of end users in the co-design, and the aim is to let's say, create innovative care solutions across various European cities. So without further ado, I turn the floor over to Professor Vasiljev, and Vanja, the floor is yours.
Thank you very much. I will share my presentation. Thank you very much for this kind invitation to share our insights from the ValueCare project. ValueCare project is much connected with SIRENE project. We use some tools like co-creation tools like you have in SIRENE project to collaborate more deeply with our main target populations. We use social innovation framework in a different way to develop and implement innovative approach and to address social challenges like, for example, aging. So I will present today some insights from the ValueCare project. As Adele mentioned before, ValueCare project is an ambitious initiative that aims to improve health and social care for older people with chronic conditions in 7 different pilot sites. We use ValueCare concept, that is a value-based methodology that is prioritizing personalized care while enhancing the health outcomes for individuals. Within this approach, we developed and used ICT solution for the purpose of validation and ensuring its replicability. I had the honor to lead work package 4, which was implementation work package in 7 pilot sites for older citizens. In ValueCare project, we are working with 17 different partners. So as you can see, it's a huge project that started in December 2019, when we had another challenge, and that is COVID pandemic that started. So throughout this project, I will tell you a little bit also about challenges that we face during the implementation. ValueCare, we have 7 different pilot sites that are facing different chronic conditions. In Athens, we had older people with diabetes and comorbidities. In Coimbra, people with frailty without social support. Cork and Kerry had population of older people with mild to moderate frailty. In Rijeka, we had myocardial infarction patients after rehabilitation. Rotterdam had patients that suffer stroke. In Treviso, mild cognitive impairment patients, and in Valencia, also mild to moderate frailty and their families. So, besides older people, those are 65 plus, we had in all 7 pilot sites target groups such as informal caregivers, health and social care professionals, and also managers of health and social care institutions. I will show you the timeline, let's say, of the project that started with co-design process. Co-design process had 3 different rounds. In first round, that was in 2021, after the first stroke of COVID, where we had to perform the focus groups, but later we developed a methodology for doing co-design via interviews. So we asked our participants what are their values and what is their current healthcare and what they need in some future healthcare from the system. So there were very interesting answers because we detected some unmet needs for the patients. Some of the answers are, I want to live without pain. I want a permission to enjoy life. I want good health to enjoy family time. I want good health to enjoy company and good food. One of the participants stated that she didn't want to be a burden. Also to enjoy the retirement without health issues more than she has already, to be independent, and so on and so forth. The co-design process included not only older people, but also informal caregivers and social and health care professionals. But here I will mainly focus on older people and their outcomes. Some timeline of the project is the co-design process, development of the ICT solution in work package 3, and testing the ICT solution, improvement, and then we started with work package 4 that included engaging of stakeholders. Stakeholders' role is to promote the project, to ensure further recruitment of the participants, and to support us in every of our activities that we suggest, or they can also suggest how to better manage the whole process of intervention. After which we recruited the target participants. It was mainly done by community nurses, or as we call it, patronage nurses, that are nurses that are working on the field in the city of Rijeka, so they enter the home of the participant. After which we train the professionals how to use the technology, also informal caregivers how to use the technology, and prior to this intervention, we also train the older people in using the technology. And I will show you how we did it. So intervention group, we had 2 groups of older people. One is the intervention group, one is the control group. Control group received usual care, and intervention group went to the process of ValueCare project, that is value-based methodology supported by the ICT. So community nurses engaged our participants when we had individual consultations with cardiologists. Cardiologists are our project members that are working in Thalassotherapy Opatija or Clinical Hospital Center in Rijeka. Together with them, the personalized care plan was set, and according to their wishes, shared decision-making process, one or all three care pathways were activated within the digital solution. Those were physical activity, adherence to medication, nutrition. Participants were monitored during 12 months. We didn't do any kind of additional interventions in our city. And after 12 months, we performed first follow-up questionnaire. And after 18 months, the second follow-up questionnaire. The informal caregivers were nominated by our participants, and they had the opportunity to also include in the project in order to reduce the burden on informal caregivers through our approach. So, how we perform the intervention? We had a general framework that all 7 pilot sites had to follow, but in each pilot site we had to adapt the general framework protocol in order to let's say, to adapt our cultural specificities, healthcare specificities, and every other specificities for a pilot site. So all pilot sites had a standard questionnaire, that is the ICHON questionnaire that is standard set for older persons. After filling up the questionnaires, of course, informed consent, our participants entered the intervention. Prior to the consultation with cardiologists, we performed the measurements of biomedical, let's say, markers, like blood pressure, like spirometry, like composition of the body with the smart scale, pulse, oxygen level, glucose levels, ECG, to see whether or not during this COVID time their health is neglected in some way. And we saw that the people didn't go to regular checkups because the hospitals were burdened with COVID epidemic. So after those measurements, they went to our cardiologist, which you can see here, and together with patient in shared decision making, the cardiologist made a personalized care plan and activated 1 or 3 main care pathways. That was physical activity, that was adherence to medication, and nutrition awareness. The results of the questionnaires were entered into GEMS Tracker. GEMS Tracker is the software that automatically analyzes the questionnaires, and the results are immediately seen in the dashboard of our cardiologists. So they can see, for example, body mass index, smoking, consuming alcohol beverages, also physical functioning, frailty, level of frailty in different dimensions like social, physical, also loneliness, sitting hours, physical activity, falls, number of falls in last year, quality of life, and overall general health. According to these data, biomedical markers, and according to this scale, our cardiologists, as I said, activated the care plans. I will not go into this table just to see that we had strict conditions for including the patients. 3 care pathways are mentioned here, and now I will tell you a couple of words about the digital solution. So every participant got the smartphone that we provided to them in order to ensure the engagement. But I have to be honest, the challenge with digital literacy was huge. So we performed the education on how to use these smartphones with touch screen, not the keyboard. Some of them got the smartwatch. Only 40 participants, unfortunately, could get the smartwatch, which automatically send the data on the dashboard, which I will show later. If we notice that our participants suffered from loneliness, frailty, or social isolation, we included them in the Viber community, which was also within the ValueCare app. And in the Viber community, we published weekly what is going on in the city of Rijeka for the older people, for the pensioners, like some courses in cooking or education and so on. This is the mock-up of our ICT solution. This is not for Rijeka, but overall. Within, we have the virtual coach. In this middle one is shown adherence to medication virtual coach, where we did not want to burden people with too much alarms. So in the morning, they got the message, you have to take your medications today. And they had to press OK, or I don't have every medicine at the moment at home, or something else which was in the list. And in the evening, they had to confirm that they took their medications. For the nutrition awareness, we had some lectures and some quizzes that we developed for our participants. This is the dashboard, and on the dashboard, we can follow and see if the patients are reaching their goals that was set up with the cardiologist. So are they performing physical activity? Are they confirming that they take the pills? In which time points? Are they taking the tests for nutrition awareness, and so on. To the dashboard, not only cardiologists have approached, but also the researchers and informal caregivers. So this is a great platform for integrated care, because every professional that is involved in the care for our participants can enter and see whether or not they are achieving their goals. So these were the components that we analyzed, and I will show you the results of our preliminary analysis. We use parametric and non-parametric tests depending on the distribution and type of the data. So our results, we were surprised. We didn't have, for sociodemographic characteristic at baseline, no significant differences, just for the educational level. So we supposed that people who are with high education, more motivated to join the intervention. So intervention group had higher level of education, and that is our assumption. The next surprising results. In all the things that we monitored during this project, didn't show any significant differences between intervention and control group in a baseline questionnaire and questionnaires that we perform after 12 months of the intervention. So we were surprised, but actually those are also good results. We believe that when we publish these results, they can help people with future projects, similar projects, to see what can they change in order to improve this kind of intervention. I'm telling you that this is only for Rijeka pilot site. not for all 7 pilot sites. In different pilot sites, there are some significant changes and improvements. Also for the loneliness, physical functioning, fear of falling, sitting hours per day, nothing was showing the significant difference between intervention and control group. Also, alcohol consumption and level of physical activity was not significantly different. Like also the malnutrition, adherence to medication, and care utilization. So to conclude this presentation, the effectiveness of digital tools, we have to admit that effectiveness of these tools in the intervention for older people largely depend on the digital literacy of this population. So we have to engage in the education on digital literacy, improvement of health education, and also to have some maybe digital tools that will provide some feedback to the participants. Digital tools should not go in just one direction, from participants to researchers, but also from researchers to the participants. Personalization of care. So we did personalized care plans, but the depth of personalization could be questioned because I think we should have had much more feedback to the patient. Measure of outcomes largely depend on patients' expectations and perception of the care they received. So also maybe they were expecting much more from us, and we did our best according to our protocol that we had within the ValueCare project. I have to say this is just for pilot site Rijeka, not for all pilot sites. You have the opportunity to participate in our final conference where all the results will be shown. So thank you very much for your attention. And if you have any questions, please, I'm here.
Thank you very much, Vanja. Yeah, actually, I have a question that is very much related to the conclusion you have presented us. So my question is connected to the value-based approach that you try to implement and to test with the ValueCare project. I was wondering if it was difficult for you, specifically in your pilot site, of course, to convey and then to implement this new approach to health and care, because I think is a new approach as the patient somehow has a more active role, and this is something that is quite different from the traditional approach that we have to care and to health, where we are more used to let's say, to perceive us as passive patients. So this is something, from my understanding, this is something very, very, very different. And I was wondering how older adults perceived, and if it was difficult or easy, or how was their reaction to this new way of managing health, in which they have a more active and I would say central role. It's not only the doctor, the professionals that is telling you what to do. Sorry, I'm not expressing in the right way, but of course you understand what I mean. But you have an important role in monitoring your, I don't know, health parameters, but also, you know what I mean? Yeah.
Yes, I understand. Well, the patients reacted to this approach very well, actually. More time with health professionals, more engagement around the patient. They appreciate physical contact. Instead, what we can see, the digital tool. I think that these interventions could be more improved if we had a more frequent physical communication with healthcare professionals, more satisfaction with this approach, and they reacted very well. For example, some suggestions from our cardiologists for the patients were, you know, for one participant, you have to stop smoking, and she said, I will not do that. So there were some resistance within the patients, but it is usual and also in their usual care. But they had a more opportunity to tell their opinion, to tell their needs. And we instructed them to say what they want from their overall health. For example, to go to supermarket, to go to have good quality time with their family, not to stay all the time in their own home because of, I don't know, vertigo or something like that. So together they could work on the improvement of the patient outcomes. But I think that major problem is so that those connections, face-to-face connections, were only twice on the baseline and in after 12 months. And they miss in between some follow-up of their improvement. And for healthcare professionals, it's different because they have to change their perspective, how to approach the patient. They are not used to ask the patient, what do you want? That was much higher resistance than from the patient. They are used to having this role of, I tell you what you should do, and then you will be okay. So this was mainly, let's say, a challenge for healthcare professionals.
Yeah, I think this is very interesting. We should go into depth in this, but I don't think we have time now. And I take the opportunity to ask another question. From your perspective, how can we, let's say, reconcile this request, this demand for presence and physical contact, as you said, that is coming from citizens, in the specific case from older adults, with the ongoing trend towards digitalization of health?
Yes, thank you for that question. I think that preparation for this kind of approach should have more space within the project. I think that one training, how to use the app or how to use technology, is not enough. It should be a preparation within the community, within our cities and different organizations, not coming just only from health, let's say, health setting. They should have the courses, how to use technology, more health education as well, and also to connect and they have to know why they use the digital solution. We need to give them the reason and to give them a good reason why are they engaging in this digital solution, not just how to use it, but what is the benefit for them and their health overall.
Yeah, so I will say that health literacy is the core, and we need to act first of all on this, then on digital skills, and then put things together somehow.
Yes, I agree. Thank
Francesca?
you, Adela.
Yes, thank you, Vanja, for your presentation. I have one more general question, let's say on the value-based methodology. As we all know, the pandemic, of course, left healthcare services disrupted in many countries. And I was thinking, after the pandemic, has not just the support, but also the uptake of these innovative methodologies been growing, or are we still like falling short of solutions, of resources to actually implement these methodologies within the facilities like hospitals or other healthcare structures?
As I can see, after pandemic, and it is the evolution of actually digital tools, the number of different apps and different solutions is growing. But the question is, are we ready? And the co-creation process is really important to ask people what they need, what they want. And as I mentioned before, to have the feedback. And also to, let's say, do these kind of tools in more engaging, fun ways. To introduce maybe gamification, to introduce some awards, to introduce some new concepts. It doesn't depend on the population. Are they older people? We all want to play a little bit, and we all want to that those applications are easy to use. Like, for example, bank app. It's so user-friendly. And they ask us, can this app look like a bank application for, I don't know, which bank you have in your own settings, because we know how to use it. So maybe introduce some gamification, maybe introduce the feedback in which way you will give them some results of their engagement, and but I think the future is in the digital tools in some way.
Thank you.
Thank you, Francesca.
Any other question? Okay, so if there is no other question, well, I would like to thank again Professor Vasiljev for presenting us with such an innovative and interesting project. Well, I feel that this has given us a glimpse of the future scenarios toward which public health should be heading. And on the other hand, I think it shed light on a paradigm shift that is undergoing in health and care. But it also told us that this shift should be strongly supported because it asks for huge changes, not only from the actors involved, starting from professional coming to citizens, but also, I will say, structural changes. Anyway, these changes are necessary, specifically if we think about the complex economic, social, and demographical changes that are happening today and that will happen in the coming years. So thank you very much. It has been really interesting. And thank you everyone who participated, and also to those who will watch this webinar in the future.
Thank you very much for